Welcome back to Brainwaves. Jim Siegler here. Quanta, the unit that describes the amount of neurotransmitter released at a nerve terminal. The smallest amount of information that can be signaled between two nerve cells. A tiny amount of information, but an amount of information that carries a punch. And today we're going to be talking about one condition in neurology, which we talk about all the time because we think about it all the time. Hopefully, you take a lot away from it. This episode, we bring to you Lyme disease, and specifically the acute neurologic complications of Lyme disease, because chronic Lyme, as you heard a bit from Adam Rodman and David Doe in a recent episode on crowdsourcing, chronic Lyme is really controversial, and for the most part, a sort of debunked infectious entity. Acute Lyme, however, can really wreak havoc on the nervous system. One day, you're enjoying a lovely hike through the woods in Connecticut, and before you know it, a tick bite has transformed you. We'll get to how that transformation happens in a minute when our program continues. We would like to thank Audible for its support of the Brainwaves podcast. With over 180,000 audio titles available to stream, there's plenty to choose from. I recommend When Breath Becomes Air by Paul Kalanithi, the heartbreaking and yet beautiful account of a young neurosurgeon in training who dies from lung cancer. These and other stories can be yours for a free 30-day trial at audibletrial.com/brainwaves. That's audibletrial.com/brainwaves. Our show begins with the introduction of the Ixodes tick, a particularly annoying little parasite that's common in the Northeast and the Midwest of the US, and some parts of Europe as well as other regions of the world. But the Ixodes tick is a phenomenal people person, loves to hang out with people, has a great relationship with them. People give him blood, and he gives them Lyme disease. Well, technically, not Lyme disease, I guess. He gives them Borrelia burgdorferi, the squatter who's just hitching a ride with Ixodes. And as you know about ticks and Lyme disease, the longer a tick clings to your body, the more likely you are to acquire borreliosis. Studies have shown that it takes a minimum of 24 to 36 hours before the Borrelia species can travel from the tick's midgut up to the salivary glands and cross over into human capillaries. But once it's there, it's there. Infectious disease physicians divide the course of borreliosis into 3 stages: early localized, early disseminated, and late. Patients with early stage borreliosis usually notice non-specific B-type symptoms, things like fatigue, fever, myalgias, arthralgias, and often with the characteristic rash of erythema migrans. This rash, which is noticed in 80% of patients and is about 80 to 90% specific for the disease, is more homogeneously red than you might think. Looks kind of a circumscribed red dot. The classic bullseye or target appearance is seen less frequently, but when you see that, it should also raise a red flag for you. After a few days or weeks, the patient will transition into the early disseminated stage, with neurologic, cardiac, or rheumatologic manifestations. For the sake of our show today, we'll only address the neurologic symptoms, which we see in about 15% of patients who had erythema migrans. And neurologically, Lyme can do a lot of really weird things. Often we think of it in the differential of subarachnoid processes, like cranial neuropathies, nuchal rigidity, and radiculopathy, symptoms you recognize as being part of meningitis. Except in Lyme disease, older docs refer to it as the Banwarth syndrome. But it's basically Lyme meningitis. And these are the most common neurologic manifestations, with the facial nerve being particularly affected among all the cranial nerves. And when unilateral peripheral seventh nerve paralysis could just be an idiopathic Bell's palsy, a bilateral facial nerve palsy does not happen in idiopathic cases. Acute bilateral facial palsy should really raise your suspicion for things like neuroborreliosis. As you might expect, with it being a subarachnoid process, CSF is often abnormal. The glucose is normal and the protein can be slightly up, but a low-grade pleocytosis should almost always be seen. And depending on the timing of the LP, it could be neutrophil or lymphocytic predominant. Besides the subarachnoid involvement, neuroborreliosis has been observed in cases with parenchymal and peripheral nerve disease. More often, cases of encephalitis or myelitis are reported in European serotypes of Borrelia, and these features develop over a few weeks, unlike the meningitis that's seen after 3 to 14 days of exposure. This is the reason why we see small amounts of white matter disease on brain MRI when Lyme disease is mentioned in the differential diagnosis. But in the absence of a history of Lyme encephalitis, I really wouldn't put much stock in the white matter lesions being caused by Borrelia burgdorferi. Moving peripherally, the late Lyme stage can cause a singular mononeuritis or a polyneuritis, and this may be unifocal or symmetric or asymmetric or multifocal, so practically any kind of peripheral neuropathy. What may help you here is that symptoms are often sensory predominant and they're distally distributed. The EMG will also demonstrate features of axon damage, so you see reduced snaps and CMAPs here without any real slowing. As far as testing goes, every lab will do it a little differently. And for this reason, I would caution your interpretation of a positive Lyme test. The Centers for Disease Control and Prevention recommend a two-step approach for Lyme disease, which we simplified on our website at brainwaves.me. Basically, the lab should start with an enzyme immunoassay or indirect immunofluorescence, tests which react with proteins that are present in serum during infections with Borrelia. These assays are highly sensitive, which makes them great for screening tests, but they are nonspecific. And here is where I caution you. If a patient has only this Lyme ELISA but no second-tier test, it does not mean your patient has Lyme disease. And I'll say this again. You need a second-tier test to confirm the Lyme diagnosis. So the lab follows up on this initial screening test, which most labs will do when you place that Lyme order, and this means they do a Western blot. The proteins identified in the Western blot are IgM or IgG antibodies directed against the Borrelia antigens, and you must have a combination of these proteins present to confirm the diagnosis. One band on the Western blot is not enough. You need 2 IgM bands for acute Lyme, meaning patients with less than 4 weeks of symptoms, and at least 5 IgG bands for subacute Lyme, more than 4 weeks of symptoms. And this is just the approach to serum testing. In suspected neuroborreliosis, an LP should be performed and paired antibody testing should be conducted, meaning the CSF to serum antibody index. But even with this level of sophistication in diagnostic testing, the results are not always perfect. Apparently, and I didn't know this until preparing this talk, CSF antibody testing for neuroborreliosis is only 50% sensitive. 50%. So you miss half the cases of patients with neurologic involvement of Lyme disease. Experts recommend that when you find serologic evidence of borreliosis and there are associated neurologic manifestations, especially things like meningismus, radiculopathy, or facial palsy, you should proceed with the treatment of CNS Lyme. Also confusing the picture, even after patients have completed a course of treatment for neuroborreliosis, the intrathecal antibodies may continue to persist. So when you think your patient has failed treatment, repeating the LP for antibodies is lower yield, and you may want to rely on the presence of a pleocytosis in the CSF. Hopefully, with more advances in science and more funding on research we anticipate with our current administration, that was a joke by the way, we will continue to refine our diagnostic methods. A quick word on treatment before we wrap up. Again, our disclaimer, as always, this podcast is for education only and should not be used to guide clinical management. So when I say that if a tick is still there, you should remove it, I don't mean you should actually remove it. I mean, the textbook says you should remove the tick. As far as antimicrobial therapy goes, the American Academy of Neurology guidelines recommend a 14-day intravenous penicillin-based therapy for cases of neuroborreliosis. I usually go with ceftriaxone 2 grams per day for 4 weeks, but cefotaxime and penicillin G have also been used, and for shorter durations. In fact, the first case of neuroborreliosis was treated successfully with penicillin, so when your resources are limited, that's a good option to choose from. If your patient has an isolated facial palsy, an oral regimen can also be used, and for a shorter course, usually 2 to 3 weeks. At my center, we offer doxycycline in this case, as long as the patient's not pregnant or breastfeeding or younger than 8 years of age. The prognosis in borreliosis is excellent, despite what you may have seen on the news. So go ahead, remove the tick, prescribe the antibiotics, and watch as the patient learns how to smile again. Sometimes, aberrant regeneration of the nerve fibers can occur, which we talked about in the episode on the facial nerve, causing some really unfortunate but very interesting problems for patients, crocodile tears and that kind of thing. So be aware of that. I think we'll wrap it up there for today's episode of Brainwaves. I'm Jim Siegler. Thanks for tuning in. This episode of Brainwaves was produced by me, Jim Siegler, music by Josh Woodward, Chris Zabriskie, Advent Chamber Orchestra, and Peter Rudenko. Brainwaves is supported in part by Audible, so go to audibletrial.com/brainwaves for your free 30-day risk-free trial. As always, you can find us on Facebook at facebook.com/brainwavesaudio or on Twitter at brainwavesaudio. You'll hear more about Lyme disease in an upcoming episode featuring Colin Quinn called It's Not Lyme Disease, so stay tuned for that.